Thank you, Shobita, and at the outset, as part of the organizing committee, I extend my wholehearted welcome to all of the delegates who are present here. We are celebrating the 10th annual PTCon conference, and we have a very good number of set of speakers lined up for today and tomorrow's sessions. I request all of you to stay back and enjoy the learning process. So, with the permission of respected chairpersons, I'll start my talk, which is basically gastroparesis and diabetes, as Shobita has already mentioned. This is one topic probably we discuss less. The problem is there, but I feel that it's been underdiagnosed because probably the investigations modality to diagnose diabetic gastroparesis is difficult and not easily accessible. To start off with history, in 1958, the unanticipated discovery of asymptomatic gastric retention in patients with severe diabetes mellitus initiated investigations into gastric function and the term gastroparesis diabeticum was coined. There is no clear consensus regarding the definition. The general consensus has now emerged. Basically, there is a delayed gastric emptying which occurs in absence of a mechanical obstruction. So, there are upper GI symptoms. We need to have an objective evidence of gastric emptying delay, and there should be an absence of mechanical obstruction to diagnose diabetic gastroparesis. Now, symptoms of diabetic gastroparesis do not just originate from the stomach, but also from the small intestine. And diabetic gastroenteropathy may be a more appropriate, more inclusive terminology. Now, in general, gastroparesis, not just diabetic gastroparesis, about 1/3 of patients with gastroparesis have diabetes. And diabetic gastroparesis affects around 20 to 50% of diabetic populations, more in type 1 diabetes and also in type 2 diabetes with a longer duration, at least around maybe 10 years of diabetes duration. Female sex and obesity are high risk factors, and thankfully, at least in one case scenario, alcohol and smoking are not necessary. All the alcohols and smokers gathering. Mortality is high. Not just because of diabetic gastroparesis, because once diabetic gastroparesis develops, that means the patient has developed all other complications of diabetes. The estimated 5-year survival adjusted for age and sex was found to be 67% in one study. Coming to pathogenesis, basically multiple mechanisms have been linked to diabetes with gastric motor dysfunction. Most importantly is motor neuropathy. There is enteric neuropathy involving excitatory and inhibitory nerves, acute fluctuations in blood glucose, high oxidative stress, and very importantly, the loss of expression of neuronal nitric oxide synthase and loss of interstitial cells of Kajal. Now, this is the basic pathophysiology of how gastric motility is controlled. GI sensorimotor functions are primarily regulated by the intrinsic or enteric nervous system, and this is modulated by the big brain or the parasympathetic and sympathetic nervous system. The enteric nervous system comprises the myenteric plexus, which regulates motility, submucous plexus, which primarily regulates absorption and secretion. Interstitial cells of Kajal serve as pacemakers and also convey messages to nerve muscles. Basically, act to initiate the peristaltic movements. Now, the movement of liquids and solids is very important while gastric emptying is considered. Liquids empty from the stomach in a more exponential manner. This is we have learned by scintigraphic studies. If you can see the extreme left-hand side of the bar, liquids go down in an exponential manner. Extreme right-hand side of the solids, which initially have a lag phase, and then there is a linear empty. Nevertheless, on an average, 50% and 100% of gastric emptying is completed in 2 and 4 hours respectively. If it is delayed beyond this, then definitely there is a delay in gastric emptying, and this is the basic investigation we need to understand whether there is delay in gastric emptying. Again, back to physiology. Now, this is how things work. We have the vagus nerve, the brainstem, parasympathetic line. There is initial funding accommodation when the food is ingested. It gives us space for digestion and absorption. Then there is funding contraction, which pushes down the food into the antrum. Here, peristaltic propulsion is taken care of by the pacemaker cells, interstitial cells of Kajal, which pushes the food further down. Then there is mixing, grinding, trituration. Ultimately, the food particles are broken down to less than 2 millimeter size particles, and it is these small particles which get passed down the pyloric antrum. When the food is pushed down, there is again pyloric muscle relaxation, which helps the food transit to occur from the antrum to the pylorus. Now, all of these things are disturbed when a patient develops gastroparesis. There is venous neuropathy, impaired founding, accommodation and contraction. There is gastric dysrhythmia, there is loss of interstitial cells of Kajal, the propulsive movements are not there. The food doesn't undergo the trituration or grinding which should undergo. The food particles do not reduce the smaller size. And along with that, there is a pylospasm, and thereby the food remains in the stomach for a long period of time, doesn't go down. Now, along with that, a lot of our diabetic patients are on multiple polypharmacy as well. These are other some drugs which can affect the motility, opioid analgesics, anticholinergics. Many patients are on depressants and tricyclic antidepressants. Even calcium channel blockers, progesterone, these are the drugs which can further increase the symptoms of diabetic gastroparesis. Coming to clinical manifestations, the most common symptoms are nausea, vomiting, abdominal bloating, early satiety, upper abdominal pain and discomfort. And the Gastroenterology Association, they use a scoring system which is known as Gastroparesis Cardinal Symptom Index, traces the severity. And it includes 9 gastroparetic symptoms like nausea, vomiting, inability to finish a meal, loss of appetite, abdominal distension, retching, stomach fullness, excessive fullness, and bloating. Complications which might develop: esophagitis, melanoma stare from excessive nausea, vomiting, malnutrition, volume depletion with AKI, erectile disturbance, vasovagal formation, and hyperglycemic emergencies as well. Now, for diagnosis, definitely as I mentioned, we need to rule out the mechanical cause. First and most important, we need to have upper GI endoscopy. If that is normal, then we go for functional test to assess gastric emptying. Scintigraphy, stable isotope breath test, as well as capsule motility test have been described. Problem is that they are a bit expensive, not easily available and accessible, and thereby we miss the diagnosis of diabetic gastroparesis frequently. Briefly about the tests we do in diabetic gastroparesis. Gastric emptying scintigraphy involves ingestion of a solid meal containing a radioisotope with short half-life, 99 technetium. Meal patterns depend on the country of residence. Western style meal, there are 2 scrambled eggs, 1 slice of whole wheat bread and 1 glass of skim milk. Asian style meals basically is a rice-based meal along with eggs, where the technetium 99 is built. Sometimes Ensure Plus meal have been used in some studies, but they are not validated. Upper limits of gastric retention at 2 hours and 4 hours should be 60% and 10%. That means 90% gastric emptying should be completed in 4 hours time. If it is less than that, that means there is gastric retention. So this is what it looks like when we do a scintigraphy. On the left side, you can see the normal gastric emptying. At 0 hours, the food is in the stomach. At 2 hours, there is around 67% emptying. Some amount of food is still in the stomach, mostly has gone down in the pylorus and duodenum. At 4 hours, there is complete gastric emptying of 100%. There is no food remaining in the stomach. What happens in delayed gastric emptying, as you can see, in 2 hours, the gastric emptying is only 29%, the entire food is in the stomach. And even at 4 hours, the gastric emptying is 57%. You can see that large amount of chunk of food is there in the stomach and small amount of food has reached down in the intestine. So this is a very important, very nice test, but problem is that it's not available everywhere. Stable isotope breath test, the gastric emptying, it is advantages that it is non-invasive, similar cost to scintigraphy, cost to scintigraphy, and there is no exposure to ionizing radiation. The gastric emptying breath test incorporates a stable isotope carbon-13 in a substrate such as octanoic acid or spirulina pratensis. The principle underlying the test is that the rate of gastric emptying of the carbon-13 substrate incorporated in the solid meal is reflected by the breath excretion of carbon dioxide. The test is conducted over a 4-hour period after an 8-hour fast. The meal empties from the stomach. The octanoic acid or spirulina rapidly undergo digestion, absorption, metabolism to produce carbon dioxide, which is exhaled in the breath. And if in that period of time we can get the carbon dioxide, that means the meal has been completely digested and absorbed.